So the first report, Halina Ivanivna Droshina. First report is dedicated for a lot of Keratoplasty school. Yesterday, today, tomorrow. Reporter head of the Department of Cornea Pathology, Professor Halina Ivanivna Droshina. Dear colleagues, for many years I have told you for the opportunity to substitute opaque cornea with a transparent one. This event was 130 years ago. Uh, Due to the impact of honorable ophthalmologists, but the main successes are of Vladimir Filatov. He was a student of a Moscow university when he began to study this question, and when he was asked in what field he wanted to be successful, uh, his answer was transplantation of cornea, and when he managed the Department of Cornea, it was his field of operation. His first total transplantation was presented in 1923, and the results were presented during the meeting of association. And in 1928 was the first penetrating transplantation of cornea. And then 5 patients with a successful transplantation were presented in the institution of capital, and they wanted to see the results because it was the first unprecedented case of such a surgery, and it was the first successful result as far as I mentioned. It is necessary to mention that at that time the technique was performed by Tripano Chipel, and it was very complicated with a lot of complications. One of them is the trauma of lens and trauma of sclera, and then they launch FM3, FM4 in order to secure this surgery. He performed in detail the stages of these operators and make better the technique. Then he expand manifestations and recommendations to do this surgery. His technique was used for many years. The main obstacle to use this surgery was the absence of eyes with transparent cornea that were the donors. Due to the reason not connected to the impairment of cornea, and as a specialist, he decided that there is no doubt eyes of people who died from another diseases don't differ from eyes of healthy people, eyes of healthy and alive donors. So that problem of searching and preserving of dead material for keratoplasty was the problem and issue how to preserve those eyes. And in 1934, he published his notices um, on transplantation of cornea from dead eyes. The conditions of preservation were +2, +4, and the results was that that material was not worse than material from alive donors. In such a way, this issue was resolved, issue of donor cornea, and also manifestation, indications and counter indications for excluding dead eyes for transplantation of cornea. He proved that dead eyes may be used for transplantation. It was his opening. And cornea was the first tissue where there was possibility to attach it and to transfer from one body part to another body part. So it was a really significant event. In 1936, by the decree of popular commissars, there was an institution of experimental ophthalmology launched, and Filatov was the director of it. And the laboratory on conservation of tissues was open. And up to the 1934, they performed 538 surgeries on cornea transplantation. And 336 of them were from dead eyes donors. Small number of people paid attention now that his contribution to the development of keratoplasty was not only his achievement, but to the transplantation in general, because the law on transplantation was adopted due to his help and assistance. Because it was a decree that the dead bodies are the ownership of state, and they can use them. It was the first law that allowed it to use dead body for medicine. In such a way, grafting was transferred from experimental method to the all-included and widely used method. Under his management, a lot of researches were made under his management. Post-operative period was described in details. That fistulas may have not only treatment but preventional effect. Then classifications of cataract and the prognosis in every other issue. The results were unified by partial and penetrating keratoplasty. Drying of cornea didn't affect on its life term, and we have to moist it in order to continue its term. So all these methods, how to preserve tissues, what morphological changes took place, all these things were opened and approved by Vladimir Filatov. Further research showed us that conservation helped to preserve this transplantation tissue. Vladimir Filatov made a conclusion that conservation in low temperatures allows to increase regenerative processes in graft and cataract of the host. Vladimir Petrovich tried to incise the upper layers of cataract and to make a partial transplantation. It was a great method and it had its positive impact. It was published in 1923. Government assessed his researches research studies, and in March 1941 he was awarded with the Stalin Premium Stalin Award of the first stage. His colleagues, bright students and followers such as Nadia Alexandrovna Puchkovska made a great contribution to the further development of keratoplasty. Due to her works, our domestic school opened a subtotal keratoplasty together with ectotic cataracts, and Nadia Alexandrovna provided optical lamellar keratoplasty. He provided anterior lamellar keratoplasty when we tried to treat severe cases of cornea. And you know that all these scientists that are listed by me took part in the further researches. There was an immune response of reactiveness and response of our body for for graft survival, and they also research different techniques of transplantation and then secondary glaucoma with cataract and the results of the penetrating keratoplasty with a donor cornea. A lot of these reports had a significant meaning, and for now we used this data in our everyday practice. On this slide you can see familiar faces. These are launches of our domestic school of keratoplasty and their followers, Susanna Alexandrovna Barhash, and all familiar faces, Tavrat Harhiladze, Ivan Halhai, and a lot of another people whose contribution was really significant to the transplantation of cornea in our institution. The name of Filatov is enlisted with the golden letters in the world history of transplantation because his achievement and opening was that we can use dead people for transplantation, and for now cornea of dead people is the best material for transplantation. His cold conservation was really significant in the history of ophthalmology. Cold conservation is being used even now in tissue banks of Europe. In 2014, American Association of Cataract and Refraction Surgeries enlisted his name to the members of Glory Hall for his contribution to the development of world ophthalmology.
For today, transplantation of cornea is a priority direction of our work. We have up to date already performed 2,000 keratoplastics, 42 of them with use of keratoxena implantations. At present, I can say that we are obtaining we are having really complicated eyes for keratoplasty. That's why the percentage of layer by layer keratoplasty has lowered, because the complications with which the patients come to us do not allow for layer by layer keratoplasty, but require simultaneous surgeries, penetrative ones. So this is the dynamics of lesion processes, necrotic processes since 2019. This percentage has been growing constantly and reached 84% in 2024. Here are some patients' cases for which penetrative keratoplasty is the only opportunity to restore vision and to avoid inflammations, to remove inflammations from the eyes. For today, we are performing different types of both layer by layer and penetrative keratoplasty. We perform combined keratoplasty with blepharoplasty, with a vitrectomy, and for today, our patients, many of our patients have terrible results of mind blast traumas, patients with opaque cornea, which require simultaneous surgeries in the posterior chamber of the eyes. So different departments of our institutions are cooperating in the operation theater. So these combined surgeries with use of keratoplasty allow to save visual functions. In a number of cases, we also are able to restore vision. The institute uses modern methods of diagnostics of corneal diseases, having modern equipment, keratotopography, OCT, and a lot of others, which allow us to obtain additional data required to prognose the prospect of the surgery. Our scientific explorations we perform cooperated with different other institutions, institution of cell therapy in Kiev City, Institute of Eye Clinics in Köln, Germany, university clinics in Münster, as well as in university clinics of other cities. Thanks to this cooperative research, we were first in Ukraine in 2001 to implement genetic research in Ukraine. We researched hereditary dystrophies of cornea. We researched mutations with certain types of dystrophies. We were the first to describe clinical form of deep dystrophy of cornea. We identified a new type of mutation associated with that dystrophy. A great number of research was held studying layer by layer and penetrative keratoplasty, and we found that layer by layer one was more sparing in both postoperative and still period. We were the first to study acute keratoconus and develop the methods of its treatment. Since 2016, we have implemented a modern method of treatment of primary stages of progressing keratoconus, which is cross-linking of collagen of cornea performed on equipment UVX 2000, and we reach the maximal effect, decreasing the time of the surgery, and effectiveness of which is high enough. We conducted a large number of research of auto serum of blood in treatment of neurotrophic keratoplasty, of post-infective etiology. We identified some criteria of corneal regeneration which influence the prognosis, and we are studying how to prognose the reaction, the response of the immune system. For many years, we have been paying large attention to donor cornea, and in 2016 we elaborated a method allowing to transplant grafts of medium size and other types of grafts with different diameter of donor cornea, and we have almost constantly been using these methods and these types of grafts. Also, we have a department of experimental clinical research where we work with new methods of research of cryoconserved amniotic membrane. We have obtained the permit to use it in our clinics, and other ophthalmologists of Ukraine got high quality amniotic membrane for surgery of neurotrophic post-infectious and other surgical procedures where it was required. We have improved the technique of transplantation of amniotic membrane, correcting the defect of stroma, lowering the number of sutures, lowering the risk of inflammatory reaction, and speeding up the epithelialization of the surface of the eye. In 2024, we were the first in Ukraine to transplant Boston keratoprosthetics of first type after severe mind blast trauma. You see the examples of this case in the pictures. His visual acuity was 0.1, and the patient is so happy, as well as we are. Speaking about the future, we have purchased laser system, modern laser system, Alcon Wave Life laser FS200, which allows us to dissect in the shape of mushroom or cylinder or other shapes, which is practically impossible to do manually. And this provides for better healing of wounds, less loss of endothelial cells, allows earlier terms for removal of sutures, and we hope that by the end of the year we will be able to operate with it. Concluding, I would like to say the quotation by academician Filatov: "The surgery of cornea does not get older, and among the transplantators there arise more and more techniques, methods, and more ophthalmologists work on this problem." Thank you very much for your attention. Are there any questions or wishes for such report. Then let's switch to the next one. The name of this next report is Pediatric Keratoplasty of the Filatov School from Past to Present. So Bobrova, Professor Bobrova is going to give this presentation.
Dear colleagues, let me present you pediatric keratoplasty of Filatov School from our present time. I have no financial interest. I won't mention all the problems of keratoplasty because they were highlighted. I want to tell you that he is an author of non-specific tissue therapy, of round stem, and another innovations. He also was interested in pediatric blindness. In 1946, when he was an experienced ophthalmologist, he was 76. He opened pediatric ophthalmology department in order to prove that penetrating keratoplasty is possible in pediatric age as well, because this complicated surgery was forbidden by all ophthalmologists, and Filatov professor at Barhaj, first managers of our department, they ruin this they ruin this thought, and they made their first surgery. And our professor Susanna Alexandrovna was the leader in performing of penetrating keratoplasty in children. On this photo, it's very rare photo. You can see the anniversary of Volodymyr Filatov. He was 80 years ago with the oldest and the youngest his patients. But of course, time changes and we have new challenges during our modern life. And now we have scarring central cataract, and they go together with different impairments of cornea, and we have to make a transplantation and reconstruction both of cornea and iris. You can see such a scar on this slide, and you can see the zone of transparent cornea if we would use the classical methodology provided by Filatov. So that's why we provided our new penetrating keratoplasty, and you can see now the pathway of our surgery. We made a big trepanation of cornea and transmit substitute opaque center with a transparent one, and to restore the peripheral zone of cornea. On the central slide you can see big scars, but we are able to incise them and to transmit, to substitute the tissue. In order to perform this surgery, we make really a lot of surgeries and researches in order to understand how to do it and where is the most transparent part of cornea. Now I want to show you a small video of the process of this transplantation. Here you can see rough scar after the trepanation. And you can see here that the iris really very thin, and we try to incise it and to separate very accurately. Then we put away cornea, extract the cataract, and implant the flexible lens in this capsular bag. Then we have no obstacles for performing iridoplastics to restore our pupil. And you can see the same procedure but with a small turn, and the central scar removed to the periphery. It became lateral. Here you can see this girl, she is 5 years old. We can see both medical and cosmetical effects. Of course, it was our achievement, and it helps us to prevent scarring in future, because there is no contact of injured cornea with the iris, and it helps us to make it survival and to leave it transparent. And then we will tell you about closing of fistula of cornea. You can see that iris wants to close this hole in cornea. We graft implant, it helps us to close this fistula and to substitute all the layers of cornea together with membrane, and we preserve the transparent part of cornea, and visual acuity was really high. And there are also different anomalies that children have when they were born. Here you can see the connected tissue at the corner of cornea. You can see also the restoration of sight and the transparent cornea. We performed iridoplastics as well. Then substitutional layer keratoplastics. I want to show you also a small video. You see that these children have this cataract big demoids of the third stage. You can see it on our video. You can see the process of removal, and there is a small additional demoid lateral. We remove this lipodemoid tissue. It is bleeding because it consists of a lot of vessels. We remove it from the surface of cornea and sclera, and then remove all the opaque layers of cornea. And after the grafting of scleral flat, on the right slide, I want to show you the rare case. A 9-month-old girl with demoid of cornea, and after the removal of this demoid and performing keratoplasty, the full restoration of vision. Also, I want to tell you about oncology. We have a lot of cases now in children. We use barrier keratosclera plastics. You see the neoplasms of sclera of cornea. It's a really very rare tumor, and after the removal of this tumor and restoration of cornea layers, we don't cover all the cornea with graft. We make a barrier in order for conjunctiva not to penetrate into cornea and to restore the construction of eye. And then you can see the process of restoration, and scleral part is on its place. And unfortunately, we have malignant tumors. You can see malignant neos. It's malignant formation neoplasm of cornea. 11 years old child. We also made this barrier in order to prevent the conjunctive process of cornea. And you can see as well this part disappears and scleral part is on its place. We also have to take into consideration pathogenesis, and there are of course some complications with vitreal bodies and then no dilation of iris and all these diseases should be fixed with the sutures, and of course we don't know the behavior of children after the operation, because it is very difficult to be in touch with the children and to conduct their behavior. Of course, we have to take into consideration peculiarities of their body and of their health. They have increased reactivity, functional immaturity of all organs, then functional immaturity of all systems, weakening of their bodies due to their previously contagious infections. What are our conclusions? Different ophthalmological pathologies of pediatric age provoke and allows ophthalmologists to improve and to provide different practices in order to resolve all these issues, in order for all children to see sun, as Volodymyr Filantov said to us. Thank you very much for your attention. Nadia Fedorivna, thank you very much for such a very fruitful report, and it is wonderful that you have such an opportunity and you propose us to use the pediatric cornea to restore this flap and to substitute a lateral part with a central part. But I have such a question. Will it increase the level of astigmatism? Yes, it's a good question. Yes, of course, because we have irregular astigmatism before surgery, and of course after the surgery we have an astigmatism in children. And there is another one peculiarity, and there are different thickness of cornea in the center and on lateral sides. So there may be a small barrier during performing this surgery, but pediatric eyes are very plastic. So all these problems will be resolved by their own body in future. And we have our own graft, of course, and we can use contact lens additionally if we have such a necessity. And another one question, not about your report, but this topic is highly discussed. What is your opinion about keratoconus in pediatric age? And what is your methodology, cross-linking or early transplantation? As to the words of Professor Serduk, I have no answer to this question because keratoconus is searched in teenage age in the Department of uh, cornea transplantations, so it's the question to Halina Ivanivna. Our approach is conservative and we use modern methods and they are effective, you know them. I want to add, what about keratoconus? If in early age we see keratoconus, we don't wait for it to progress. We have to perform cross-linking at once because early keratoconus progresses very quickly, and we have to prevent keratoplasty because keratoplasty is exclusive, unique case when we have keratoconus in early age. We also have cases of acute keratoconus in pediatric age, and we also don't perform keratoplasty. We make a surgery to prevent glaucoma in order to decrease the pressure and to treat this child.
So the first report is going to be by Sereda Katerina Vitalievna, treatment tactics for fungal keratitis, the role of penetrating keratoplasty, the Department of Cornea Pathology of our institute. Good day, dear colleagues. Let me present my report on treatment tactics for fungal keratitis. Fungal keratitis is an urgent, dangerous infection of the eye, mostly widespread in tropic and countries, developing countries, and it makes up 67% of all cases of infectious keratitis. Fungal keratitis is mostly suffered by men who work in open air, and it was first described in Germany by Leber in a 54-year-old farmer. This infection has to be considered as an urgent need that requires increased familiarization of an ophthalmologist for correct clinical diagnosis and urgent treatment, because really often, even after early diagnostics, loss of vision is inevitable. Besides, antifungal treatment are of high toxicity and low effectiveness somehow. The morphology and classification of fungi is different, but the most widespread type of fungi are unicellular yeast. Filamenous fungi are spread into several sections, several types. There are also yeast fungi, which form cream-like colonia on the surface of cultures or environments. There are also dimorphic fungi which have the properties of yeast. Risk factors of fungal keratitis from the eye are wearing contact lenses, chronic diseases of the surface of the eye, immune suppression, too much use of anesthetics, previous operations of cornea, cornea trauma by ground or organics. There are also systemic factors which contribute into the risk. Speaking about epidemiology, we have to say that Aspergillus is the most spread organism in the whole world. Its morbidity is varying geographically in the north of the USA, there's Candida and Aspergillus. In the south, there's Fusariosis. The pathogenesis is the defect of epithelium of cornea. It causes inflammation and necrosis of stroma, and then penetration takes place through undamaged descendant membrane into the anterior chamber. Clinical manifestations of fungal keratitis are feeling of foreign body, increasing pain, decrease of vision. There might be specific and non-specific symptoms like feathered mushrooms, raised edges, epithelium defect, fixed hypopyon, yellow demarcation line, immune ring of Wesley formation. Keratitis fusarium has severe course of fusariosis. There might occur perforation within 2 or 3 weeks. Other clinical peculiarities are white, yellow or gray lesion, raised edges, satellite lesions. Among laboratory studies, we can perform scraping of cornea. We can also turn to laboratory diagnostics, direct microscopy or confocal microscopy, PCR. Treatment of fungal keratitis is generally problematic. There are no commonly accepted recommendations for this. Usually one or several antifungal preparations locally are combined with intravenous administration or per os. Mostly amphotericin or natamycin are prescribed. The most spread polyens are amphotericin B and natamycin. The first one does not penetrate into the intact epithelium, has low or moderate activity against Fusarium and Aspergillus. Natamycin is highly active against the majority of Fusariosis and Aspergillus. It can be intravenously or intracamerally administered. It cannot be intravenously or intracamerally administered. The most spread solutions are voriconazole 1%, fluconazole 0.22%, which provides for good penetration into the eyes. You may see the solutions percentage in this slide. Itraconazole, for example, is often used for long-term and support treatment of chronic fungal keratitis. There is also povidone iodine and the latest generation of preparations, allylamines, echinocandins, are also used these days. Indications to systemic antifungal treatment are large ulcers of cornea, scleritis, endophthalmitis. Per os, ketoconazole is mostly used dosage 600 milligrams per day. Each 2 weeks, liver tests has to be done, and systemic therapy should last from 6 to 8 weeks. The algorithm of therapeutic treatment has to include testing, diagnostics, and then choice of different types of treatment depending on the response from the organism. If the therapy provides for nice effect, then it lasts from 6 to 12 months. If the response is bad, then we are speaking about systemic treatment, intrastromal, intracameral administration of preparations. Surgical treatment of fungal keratitis includes transplantation of amniotic membrane, which decreases pain, inflammation, and neovascularization, stimulates epithelialization, decreases scarring. Also, we use conjunctival flap, thinning of cornea with threat of perforation ulcer resistant to treatment. Intrastromal injections are also possible in 4 or 5 zones around the abscess, or infiltration intracameral injection when preparation is administered with help of needle to facilitate intrusion of exudates or hypopyon. Cross-linking is also possible. It destroys the DNA and RNA of the minor microorganisms, but for now, its effectiveness is questionable. The key moments for therapeutic treatment keratoplastics are trepanations for 1.5 millimeters from the damaged area. We always use sutures. We interrupted sutures. We irrigate the anterior chamber with antifungal preparations. We remove the damaged intraocular structures. We recommend systemic antifungal treatment. We use steroids in such patients, but this is questionable. Let me also show you a couple of clinical cases. We had a patient, 53 years old, wearing contact lenses 2 weeks ago. She noticed redness in the eye and some discomfort. So her questionable diagnosis was herpetic keratitis, and she was treated with antibacterial and anti-inflammatory preparations. She had almost penetrating infiltration of the stroma to almost up to the limbus. She had hypopyon. We performed confocal microscopy, which showed numerous foci of fungi. So her treatment included chlorhexidine, fluconazole, voriconazole. She had intravenous infections of some preparations. Because of the abscess and different risks, we performed penetrative tectonic keratoplasty with basal iridectomy. We found fungi resistant to all the spectrum of the preparations available in the laboratory. The patient continued getting fluconazole. On the 7th day, post-operatively, we found formation of infiltrative screen behind the transplant. So after 2 weeks after keratoplasty, we performed another surgery. On the first day, the infiltration was absent and the patient was discharged after 12 days. She was followed up. The surface of the graft was stably epithelialized, and in a month, in the follow-up, the condition of the graft was stable, so there was no recurrence. Our second clinical case is a patient of 70 years old who was traumatized by a plant during working in the field. She was treated by steroids. We found deep infiltration, we found stroma in biomicroscopy. We also performed confocal microscopy and found fungal etiology of abscess and diagnosed her with this abscess of cornea of fungal etiology. We treated her with chlorhexidine, fluconazole. We performed combined treatment and decided to wash the anterior chamber to take biopsy, which showed us Aspergillus flavus resistant to many types of treatments. In connection with the prognosis of thinning of cornea, we performed penetrative treatment tectonic keratoplasty. On the 14th day after the surgery, the patient was discharged with stable condition. No recurrency was found. The graft was transparent and her visual acuity was 0.02. After a month, post-operatively, she was stable as well. No recurrency was found. Our third clinical case was a patient of 48 years who was traumatized during working in his garden. Again, he was treated by antibiotics locally and systemically. Then he was referred to inpatient treatment. Hypopyon was found. His visual acuity decreased very much. There was the infiltration of stroma. We performed confocal microscopy, and our diagnosis was post-traumatic ulcer of cornea of fungal etiology. We used fluconazole, chlorhexidine, and other preparations combined with intravenous injections and per os. We performed washing of the anterior chamber with sampling for microbiological research, which showed also Aspergillus flavus, sensitive to voriconazole. Because the patient's prognosis was for thinning of epithelium, we performed penetrative keratoplasty. Unfortunately, on the 9th day post-operatively, he had recurrent infiltration. So first of all, another washing of the anterior chamber was performed, and after a day, when hypopyon was absent, we performed transplantation. The patient was discharged after 14 days after the secondary operation with visual acuity 0.05. 2 months post-operatively, the condition was stable. There was no opacness in the graft. So to conclude, we have to say that keratitis caused by filamentous fungi such as Aspergillus, in absence of proper and timely treatment, can gradually become endophthalmitis and threat the eye. Samples of cornea remain the golden standard of etiological diagnostics. Confocal microscopy helps to diagnose fungal keratitis at early stage, but in hard cases, in severe cases, there has to be penetrative therapeutic keratoplastics performed. Thank you for your attention. Thank you, Katerina Vitalyevna. Does anyone have questions? Good day, everyone. Thank you for your wonderful report. Please tell me, do you use povidone iodine? I haven't heard it in your report. No, we don't use it, but we use 1% voriconazole and fluconazole. Yes, these are antifungal preparations, but how about antiseptics like povidone iodine? No, we don't use it, but we use chlorhexidine in combination with voriconazole. Thank you. And the second question is, I often see combination of fungal infection in hepatic eyes, in hepatic ulcers. What do you do in these cases? These patients are treated with valacyclovir. And which preparations are used locally against the fungal infection? Yes, the same. Fluconazole, voriconazole, because based on our experience, these are the most effective preparations. Some of preparations are just inaccessible these days, but if there is stromal process, for example, some preparations are inaccessible. And can I ask a question too? Thank you for your wonderful report. Please tell me, in your practice, have you ever compared different antiseptics like miramestin, olcomestin, povidone iodine, or chlorhexidine? Have you ever compared them? Statistical studies were not performed by us, but speaking about clinical effectiveness, which we see in infectious keratitis, chlorhexidine is more effective than miramestin. Thank you very much for your answer. I also have a question. How is it critical to determine the type of fungi? Does it change the tactics of treatment? And how can you perform your research, because the data is really limited? So the data from our presentation are coming from the world experience. So Candida fungi has clinically specific properties, and we can sometimes suspect it. Also, Candida has more specific amphotericin. Other fungi are more sensitive to fluconazole, but when we suspect fungi keratitis, the first line, the first choice preparations are the ones that I mentioned from what is accessible by us. What happens if there is a combined flora? Which flora do you see in combination with fungal one? We see streptococcus. Thank you. And I have a question. Yeah, I would like to add to Oksana Sergeyevna's question that, speaking about the clinics, fungal keratitis are factors which develop a little slower in Candida case than in mold case. Mold cases progress more severely and faster. So this factor also shows us indirectly what type of fungus we are dealing with. I have a question. When we diagnose fungi, we see it in confocal microscopy, but our patient has epithelialized surface of cornea. Do you recommend to perform scarification because if the zone is limited, or should we just treat the patients even in cases so when the treatment doesn't help for months? So if there is a focal effect, then we don't perform epithelialization at once. But if we see absence of effect of treatment, we take more serious measures. Is it scarification or is it intrastromal injection? First of all, it's scarification. Thank you very much. Speaking about povidone iodine, you mentioned it in your presentation. So the percentage which you specified, how can we get this percentage? How do you dissolve it? So this chlorhexidine from the pharmacy is dissolved in the natrium chlorine. We have pharmacological solutions already, so that's why they are widely used. Thank you very much, Katerina Vitalyevna. We are switching to the next report.
Because of course we are out of time, and we invite Saldan Yulia Yosipovna with a report papillomavirus from pilot to practice. Vinnytsia National Medical University, named after Pirogov. Good day, my colleagues. I want to thank for the beautiful, brilliant organization of this event, and to thank personally to the Department of Cornea, because nevertheless all the specialists are sent, all the severe patients are sent to you, and you have the biggest experience. What about my today's report? I chose the topic papillomavirus, human papillomavirus in ophthalmological practice, because there are a lot of discussions about whether it is necessary to be vaccinated or no. So let's talk about it. I have no financial interest. So let's start. A virus of papilloma are caused by a specific virus, and the human being is a carrier, and it is a sexually transmitted virus. It can infect eye surface. So it is transmitted with a hands-on conjunctiva and on cornea. It's a chain virus without and there are several stages for its development. It's epitheliotropical virus and infect epithelial cells, basal membranes, and implement in the DNA of the host. It has also oncoproteins. It changes the development of normal epithelial cells. It's the suppression of host cells and inhibition of telomerase, and it decreases the cycle and chromosome instability. But during a long period of time, it wasn't typing, and it wasn't attacked by immune system of our body. And there are more than 100 types of these virus. 14 of them are highly oncogenic. Clinical signs of papilloma. It is developed during the first decade of life. It looks like nodules with vessels, so that's why they are pink. Children may be also infected and during the delivery. For these papillomas, spontaneous regresses is a very characteristic sign. Nuclear pyknosis and transparency of cytoplasma are the main signs. As to the character of growth, they can be exophytes. They are also divided for one with a leg and without leg. Clinical signs of papilloma presented on this slide are characterized by the widespread for conjunctiva, stems 6 and 11 that are non-malignant, and 11th and 18th that are malignant. As you can see, they are subdivided for ones with legs and without legs. Those with legs, they are non-malignant. Without leg, they are malignant. And non-malignant are usual for children and teenagers, and malignant are normal, widespread for adults. And here you can see further derivation of eye impairment and division into malignant and non-malignant. And of course, there is the cases of recurrence. It's 5-11%. Here you can see different diseases, keratosis, cysts, malignant impairment of surface epithelium, different neoplasms of conjunctiva, and flat cell cancer, papilloma granuloma that is produced near the sutures, and several types of hemangiomas, non-pigmented melanomas, and different secondary tumors. In any case, to establish diagnosis, you should perform a biopsy. Options for treatment: it's surgical removal, cryotherapy, and laser as well. Despite of the modern methods of treatment and surgical treatment, all papilloma can be recurrent. These recurrency cases can be in from 6 to 27% of cases. I want to show you first clinical case. Patient who addressed us. She is 52 years old. Her diagnosis is Hodgkin lymphoma, and this papilloma has two surfaces. It is very interesting fact. The surface was covered with the skin, inflamed skin, and opposite cover, it's the cover of papilloma. So it grows on margin edge, on affected edge. After the surgery, we investigated this neoplasm, and it was fibropapilloma. It developed very quickly, and usually we have such cases in immune incompetent patients. The second clinical case, as far as I mentioned, during the long time, papilloma are unpainful. and it's only a cosmetic defect. But if we injure such neoplasms, we have an immune response. It's the second clinical case. Patient 62 years old. It's an urgent case. He was gardening and there was a foreign body in his eyes. His eye was injured by a stick. There was an inflammation of eye and we saw neoplasm on limb. There were also purulent discharges. We prescribe anti-purulent therapy and decided to perform a surgery. We investigated this neoplasm. We made a barrier on cornea. And during the investigation, we find out that it was papilloma with signs of frozen of covering. Of course, we have to perform a treatment against malignant tumors. For today, we have 3 types of vaccines to prevent papillomavirus. In Ukraine, this vaccination is not for free, but next year the first dose of any vaccine will be for free for girls beginning with 9 year. Why we choose this age? Because it causes oncological changes of uterus. It's the first and main cause, and we should assess all the changes and the impact of this vaccine in conjunctive cavity. Also, we have to mention the signs of malignant tumors because when we plan a surgery, we should understand the image. It's atypical cells, and these tumors are very big. There are metastases, ulcers, and these tumors influence the whole organisms. Conclusions. The most effective way to prevent is vaccination. When you have neoplasm, it is necessary to take into consideration signs of manifestation and then to perform cryocoagulation of healthy tissues. All tumors should be examined even if you are sure that this process is not malignant. Thank you very much for your attention. Thank you very much for very interesting report. Do you have questions? So please, Nadia Fedorovna. It's very relevant and a wonderful report, but now we are in such a period when this oncology uh, has a lot of morphological changes, and you don't know when you have a surgery on removal of tumor, and you don't know whether it is malignant or non-malignant. Taking into consideration this practice, I don't perform biopsy. If there is a proper size, proper location, I try to remove the whole tumor, taking into consideration safe edges and all the necessary precautions. And then I am waiting for the results of examination. And how often do you use biopsy? And tell please about its relevance. Thank you very much for your question. Of course, there are we can see different morphological changes and signs in one removal fragments. It can be inflammation, papilloma, and signs of malignant process. We perform biopsy if we have a big formation, a big neoplasm, and we should plan, we should schedule our next steps because we are not able all the time to remove to a big tumor on our eyelids, for example. That's why it is relevant to make biopsy, and after biopsy we take a decision about further removal and to understand what we need, substitute tissues or some other measures. Very briefly, because we are out of time. The thing is that when you use cryodestruction, it doesn't kill virus. Only laser coagulation helps us to kill the viral DNA. How do you take decision what type of treatment you should use? There are a lot of publications on cryodestruction. I don't use it because for now we don't have it and it's irrelevant method. So for us now it's only coagulation. Thank you very much, Julia Osipavna. The next report, complex treatment of neurotropic keratoplasty.
Please, Lyudmila Fedorivna.
Побічні прояви та особливості лікування реакції трансплантат проти хазяїна.
We have had a mistake, so now we are going to have a different topic of lecture. Eye manifestations and peculiarities of treatment of transplant against recipient disease. I don't have any financial interest in the report. So autologic and allogenic transplantation of hematopoietic cells is an important variation of treatment of various malignant tumors, including leukemia and lymphoma. In the US, annually, there are over 20,000 procedures. In Ukraine, the transplantation is taking place in 11 centers. Despite the fact that immunosuppressive therapy has been advanced and better typing of leukocytal antigen of human HLA, the disease transplant or graft against the recipient remains a widespread complication, which is seen in 30–70% patients. We observe acute or chronic reaction. So acute reaction includes the most crucial clinical consequences which associate with skin, liver, and eyes. Chronic manifestations, they include destruction of skin, fibrosis of derma, severe recurrent infections on the background of the basic lowering of organism's immune system. Eye manifestations occur in 40–60% of patients, and they include dry keratoconjunctivitis, scarring conjunctivitis, dry eye disease, corneal ulcers, cataract, non-infectious uveitis, as well as central serous chorioretinitis. There are 4 stages in lesion of conjunctiva. 75% are at 3rd stage, and over 75% of the surface is considered to be the 4th stage. Sometimes it leads to fibrosis, sometimes it is inevitable to have the dry eye syndrome. The cornea has formation of upper limbus keratoconjunctivitis, neovascularization of cornea, ulcers, cataract formation. It's widespread in the cases of this disease, graft against recipient. The posterior chamber of the eye has to be diagnosed and researched. General examination of patients with manifestations of this disease include general ophthalmic examination. We look at the anamnesis, we photoregister the eye, we perform Schirmer's test, Noon's tests, OCT of both anterior and posterior chambers, phosphine, and other methods of examination. There is also a different system of examination of patients where we grade the stages from 0 to 3. You can see these gradings in the table here according to the scores, where the most severe case with dry eye symptoms is significantly affecting ADL, the special eyewear to relieve pain, or unable to work because of ocular symptoms or loss of vision due to KCS. Speaking about the principles of patient management and treatment those with ophthalmological manifestations, we have to follow the basic principles of systemic and local treatment. The systemic one is prescribed simultaneously with local one and sometimes includes steroids. The degrees of drainage, the humidification should be performed with hyaluronic acid, with dexapantanol, ointments. We also have to decrease the inflammation of the eyes by use of local steroids, controlling the intraocular pressure at the same time. We have to use topical cyclosporine, decreasing the immune response on the surface of the eye, and taking vitamins, providing for healing of the surface of the cornea. Also, hygiene of the eyelids has to be followed. Sometimes warm compresses, doxycycline combined with other listed here preparations has to be performed. The patients has to feel the improvement of the surface of the eye and protect it. Surgical treatment of eye complications of the disease include focal occlusion, tarsorrhaphy, transplantation of amniotic membrane, which may be used for treatment of severe dryness of the eye, degeneration of cornea, with or without perforation. And the last method of surgical treatment is deep anterior layer by layer keratoplasty or penetrative keratoplasty, which may be used in extremely severe cases. This table shows the scheme of patient management with ocular manifestations of GVHD. In the most severe cases, this is the use of terceraphy, Prochera, or amniotic membrane transplantation. Retrospectively, up to 2023, we had 3 patients, all women, 52, 32, and 26 years old. The patients had both eye lesions. All patients were systemically treated. The clinical manifestations included light sensitivity, stable pain syndrome, OSDI was increased up to 100 scores in 2 cases. The cornea was painted. Schimmer's test showed 1 millimeter, 5 and 2 millimeters respectively in our patients. Main clinical examples of treatment of these patients included focal keratopathy and ulcer of the cornea. We used antiseptics without conservants. We used artificial tears. The percentage of solutions are shown here on this slide. We used eye drops with the otological serums. We used ointments with vitamin A combined with hygiene of eyelids. As a result of long-term complex therapy, all the patient's condition improved. OSDI lowered to 75, 62, and 78 scores. The pain, the coloring of the cornea with fluorescein did not was not over 2 scores. The formation of tears also increased. Positive changes was followed with increase of visual acuity. We also performed amnioplastics with blepharophy. It did not show significant results, so lamellar keratoplasty was performed in the end, and only then the clinical effect was stable and successful. Thus, this disease, graft against the recipient, is still a really widespread complication after transplantation of hematopoietic cells, which occurs in 30 or 70% cases. Long-term use of systemic anti-inflammatory and immune suppressive therapy combined with local antiseptic and anti-inflammatory artificial tear therapy leads to successful results. Thank you very much for your presentation. Unfortunately, we don't have any time for questions.
The next report, modern perspective on parainflammation in dry eye disease. Vinnytsia Institution of Eye Diseases. You're welcome. Good day, dear colleagues. Today, my report will be dedicated. Sorry, some technical issues. My topic will be the issues of parainflammations. These are new mechanisms that are studied by ophthalmologists all over the world that include in pathology of eye. I have no financial interest. So let's talk about parainflammation. During the last 2 decades, we understand the origin of eye dry disease and we changed our vision and understanding of pathogenesis and another science. But this pathology is connected uh, to tear cover and eye inflammation. Then you know that there were Dias 2 sessions, and this disease was connected to chronic inflammation. In 2023, Michael Stern and Stefan Barabino made a theory that acute inflammation is associated with tears. It increases the level of cells producing the cells and influence on the surface of cornea. The the density of cells, of course, are affected, and of course, diaplasms of conjunctiva and decrease in cornea sensitivity, changes of conjunctiva epithelial cells. What about history? In 1994, Gabriel presented the concept of parainflammation. These are forms of inflammation with a moderate but stable immune response without signs of inflammation. And in 1208, it was an intermediate state between homeostasis and inflammation caused by stress, change of environment, so stable signs and systemic changes in organism. And parainflammation is the support or recovery of homeostasis, so it's a key for treatment. Very briefly, I want to tell you the diagnosis between types of inflammation, parainflammation, subclinical inflammation, and chronic inflammation. Parainflammation is adaptive response of our body. It's a local response without inflammation, with a low level of cytokines and active inflammation of cells. Subclinical inflammation is inflammation without clinical signs, but we have biomarkers in tears and in eye tissues. There are biomarkers of inflammation that can be revealed by tests. Chronic inflammation. It's a long-term inflammation process with step-by-step impairment of tissues. We have cell infiltration, macrophages, and lymphophage. And then clinical inflammation. It's inflammation with rushing, with tearing, pain, and we have a very bright and active clinical picture. What do we know for today? In 2023, there was a European meeting of experts on dry eye disease, and they discussed the evidence of pathogenesis and mechanisms of parainflammation and inflammation, changes of lipid-mucin, parainflammation and inflammation, and cortisol. Our hormone cortisol is paid much attention to. It's a disbalance between impairment and and protective mechanisms. So it's a functional response of our body. Immune response during the eye dry disease, it's not only one type of immune response. We are talking about adaptive and born immunity. What about beyond born immunity? It's a first response of epithelium of our eye cells. We have TLR4, TLI9, and then infiltration by macrophagus, neutrophil, and activates the cell ptosis, and then it's reveal of IL-6, IL alpha and beta, and then we include adaptive immune response. What about our activation of adaptive response? We reveal IL-17, and they can provoke autoimmune response. It is very important when a patient has Sjogren disease. And then impairment of control may cause the reaction of adaptive immune response because normal inflammation reaction makes indifferent the makes impossible impairment of tissues, and it helps us to prevent from born immune response to adaptive response. So our born immune response is crucial when we are talking about eye dry disease. It helps to decrease it and to treat. And because when our tear cover is impaired, our born immune has to help to overcome this state. Then, when born immune response is high, we can prevent this disease to be chronic and to use target therapy. Our modulation of born response is a prospective way for development. Therapy can influence both on born and adaptive immune response. There are new approaches for personalized treatment. For today, what strategies we have for control of perinflammation or inflammation? There were a lot of researches, and there is no one conclusion on specific ways of treatment in order to decrease parainflammation of eye. But local steroids are the most effective uninflammation medical products. For today, the biggest role play the substitutes of tears and modulators of eye surface. They should be used on a constant basis in order to reduce this burden with the immune cells that were activated during the born immune response activation. And then we studied this disease caused by diabetes mellitus group 2. We have subclinical parainflammation types of inflammation. The systemic immune response influence of on our systemic immune response and on our tear cover. This treatment help us to ruin these cells. So that's why parainflammation is a very acute and relevant topic when we are talking about diabetes mellitus. The influence of diabetes to this disease is covered by the Association of Diabetes Mellitus. There can be hyposmolation of tear, decrease of density, and in other signs. So there is direct connection of diabetes mellitus and dry eye disease, decrease of mucin level, and activation of bone chain of immune response. Immunocytology of patient with diabetes mellitus group 2, 80% with diabetes mellitus have flat cell metaplasia, and the stage is irreversible. And there was interest in the inflammation by macrophages and neutrophils. In 28% of patients, there was also an expression of CD15, activation of neutrophils in 65% of our cases. So it's a specific biomarker of parainflammation and inflammation processes in patients with diabetes mellitus. What about TL liquid in patients with diabetes mellitus? As to our researchers, the amount of general mucin, the decrease was by 30% compared to patients without diabetes. And then we have oxidated glutathione and non-oxidated glutathione, and we can see also the decrease. Strategy of treatment of such patients, it's a compensation of diabetes mellitus, normalization of blood glucose, normalization of lipidogram, then therapeutic hygiene of eyelids, tear substitute therapy with a mild effect that will influence on the bone immune response. And taking into consideration the impairment ethiol status, antioxidant therapy should be included. Of course, it should be without conservatives. Results of our researchers, as together with our therapy, increase of the density of cells, and the decrease of infiltration in 67%. Markers of eye impairment that can show you inflammation or parainflammation. TNF, MMP, MAC-C, expression of CD15 on epithelial cells, and of course increase of T osmolarity, decrease of density of cells, and impairment of antioxidant system. So parainflammation is our protection immune response. By its activation cause chronic process in our body. It's a central chain in eye dry disease pathogenesis, and it influences on the dysfunction of our eye. Modern therapy should be oriented on moisturing and control of this process. It can increase the effectiveness of treatment and quality of life of our patients. The last slide, I want to cite one of the specialists. He compares parainflammation with the equilibrist. You see this man. You see this man on this image, and he tries to keep the balance, but we won't be able to keep balance all the time. So our main task is to control parainflammation. Thank you very much, Tatiana Mikhailovna, for this fundamental and interesting report.
This is Averyanova Oksana Sergeyevna with co-authors New Cross-Linking Protocols for Subthreshold Thickness. Kyiv, ILAS Medical Center. Today we see that keratoconus is more often observed, and it becomes younger and younger, manifests in younger and younger patients, probably due to change in ecology, due to increase of number of autoimmune diseases. In our practice, we follow the global consensus made and published in 2015, and our specialists who worked on it made several conclusions which we use. We understand that it is commonly accepted that cross-linking is the first line, first choice treatment. Why is that so? Because there is a very small percentage of complications, up to 3%, and the effectiveness is high enough. Only 6% cases have progressing keratoconus. We know that cross-linking takes place in over 83% cases, and it allows for the Fuchs dystrophy becoming on the first place among all cases of keratoconus. Unfortunately, today there is no upper or lower age limit for cross-linking. Our youngest patient was 9 years old, and the oldest was 64 years old with proven effectiveness. There is no consensus as to the procedure because of absence of progressions, but we treat pregnant women, we treat children with it. Sometimes people who have triggers like thyroid gland diseases or autoimmune diseases, they are the patients within the risk group, but in this case we offer keratoconus treatment to them, and this is their choice if they agree to cross-linking or not. Usually they agree because there are really few complications possible. Speaking about correction of visual acuity, after such treatment, any type of correction can be used, chosen by either physician or by the patient. Speaking about the term and demarcation depth, we know that the depth depends on epithelialization and infiltrations on account of the fact that the procedure takes place faster, and we can decrease the time for the procedure and remain within the dosage which has to cause thickening, higher increase of density of the cornea. We use our knowledge of where demarcation line is located depending on the age of the patient. We know that we can perform it with epithelium or without it, removing the epithelium. But when we leave the epithelium, we see that the recurrency or further development of keratoconus is higher. So physical limitations, age limitations, they play certain role in the process. We take patients with different systemic diseases, like children with Down syndrome We
І
also
зрозуміло, що
work,
людям хочеться провести
we
прослідку,
sometimes
подивитися
want
повністю
to perform
коли
cross-linking and not
під час
transplant
уваги
the
системи. І
cornea.
ми можемо мати ще і
So
досить
we
гарний і досить
would like
нормальний
to preserve
кровообіг, але
our
може
patient's
викликати
visual
фізіологічно
acuity,
простір
but we don't want the
процедуру
cornea
прослідки.
to
В цьому
thin.
плані ми можемо використовувати і
That's why we can
потовщені
use
розширення
hypotomic
трішечки потовщити
solutions
плівку.
to
На певний
thicken
час застосовуються
cornea. For a
більш
certain
щільні
time, we used soft contact lenses without UV filter in order to perform cross-linking. But today there are
вони построєні на той самій
in
схемі, що ми
nomograms
можемо
of
ущільнити
shortened cross-linking
кровообмін і зменшити
when
час
we thicken the
кровообміну.
energy flow
Чином,
and
скажімо, досить
decrease the
безпечно достигнути до
impact
високих
period
розмірів демаркації
in
певних
order to
і
reach
виконувати
certain
піддосу
demarcation line
необхідні.
and
Коли
use the
можна це зробити?
dosage
Звичайно, що це можна зробити
which is proper for us. Surely we can do it with children with developed keratoconus, with the thin cornea, but we would like to postpone transplantation of cornea. We also wish to perform it in patients who are satisfied with their visual acuity. The procedure lasts 30 minutes. In cases if the thickness of cornea without epithelium makes up 3 micrometers. So the demarcation line, demarcation limit has to stay within the safe threshold. We have performed the following research of 165 eyes with thin cornea, and we have 3 criteria, 3 factors when we can say that the procedure was safe. So first of all, it's confocal microscopy, then it's progression keratoconus protocols when we follow if the keratoconus is progressing or not. In this table, you can see assessment of dynamics with help of progression protocol. You may see that the demarcation line is where it was calculated to be. Follow-up of this person takes place within a year post-operatively, and you may see that this protocol does function and the progression of keratoconus stops. What are the results of our job? First of all, it's safety, because in none of the cases we saw complications. There was no damage of endothelium, and we obtained demarcation line where it was theoretically calculated, meaning that we did not cross the demarcation line. And we have a second result, which is effectiveness. However, we have a couple of cases which are, I would say, tragic. We had a patient 14 years old with keratoconus for 3 years, third, fourth stage. You can see that we performed accelerated cross-linking for 10 minutes because the thickness was too low, and you can see the epithelium effect where the epithelium was 301 micron. We chose the protocol for 300 microns, calculating the time for our patient's thickness. So here you may see that everything is in its place. With the scleral lens, the visual acuity is 0.65. Another patient was 24 years old with keratoconus of 4th stage. The visual acuity in one eye was a little better than that on the other. You can see here her dimensions, her thickness. only 107 microns for stroma, and all the rest was for the epithelium thickness. So we made OCT to make sure that there is no effect on the epithelium. We chose her protocol for 9 minutes, expecting demarcation for 250 microns, and the result was as we had calculated. Here are the images of microscopy with thickening of the corneal layers. Everything went well as we had planned. And another patient of 18 years old from Kiev City had decrease of visual acuity for 1.5 years. He complained to his parents, but his parents did not pay attention to it until they referred to us with keratoconus of 4th stage. Unfortunately, he came so late with such dramatic decrease of visual acuity. We made topogram, we made OCT, and saw his thickness 264 in the right eye. So we chose his protocol for 283 microns demarcation. You can see that there is still some thickening, there is still some collagen linking in 260. The stroma was normal as well as the epithelium. After the operation, we found customized lens for him, expecting follow-up and expecting transplantation of cornea in this case. Among our conclusions, we can say that use of nomograms, thin cornea for cross-linking is safe and effective. OCT and confocal microscopy are reliable methods for diagnostics of thickness of cornea and demarcation line and endothelium stage condition. Thank you very much for your attention. Thank you, Oksana Sergeyevna, for your interesting report on such severe cases.
The next report is impairment of cornea and eye surface damage when there are skin diseases. Please reduce if you can. Good day, dear colleagues. Today I want to present to you a report on impairment of corneal and eye surface at the dermatological diseases. As ophthalmologists in our practice, we have dermatological diseases that cause eye inflammations and vice versa. Most often, the reasons are rosacea, acne, dermatitis, psoriasis, and in other clinical case, a patient 36 years old, decrease of visual acuity, redness, and fear of light. We know that he has a low sight from childhood. He didn't wear spectacles or lenses, and no compliance from other sides, no other compliance. Objective picture, we have OD, mucus and purulent discharge from conjunctiva, and in external layers of stroma, a big veil, and neovascularization of limb. OS is proper light projection, and also mucopurulent discharge, vascularization of cornea, and lymph vascularization, and vision is 0.03. Pressure is normal, and in other indications as well. But we pay attention that he have a lot of pustulas on his beard and on his hair. So this stage he has had for several years, but he hasn't paid attention to it. Photos are illustrative because he didn't give a consent for his photos illustration. So we perform additional examination of urologist and another specialist remo tests are within normal change. Then bacterial scrap was within normal range. Dermatologist consultation. Diagnosis: psychosis. It was caused by staphylococcus, and it impairs men of 30-40 years in the areas of mustaches, beard, and hair. It is characterized by forming of follicles and forming foci. The diagnosis was established. Um, so OD, subtotal vascularized opaque of cornea, OC, flictonalosal keratitis. And what about treatments? Hyaluronic acid, oxytocin, streptocin ointment, dexamethasone. Non-steroid medicines, tetrazolene, amoxicillin, intravenous calcium gluconate, ascorbic acid, dimedrol, dexamethasone. Here you can see the prescription and the state of patient in a month. You can see that surface was epithelialized and the vessels reduced. There were some focal opaques, vision OD 0.03, vision OC 0.14. Conclusions. We want to highlight that it is necessary to see the connection between dermatological diseases and eye diseases, because we will have good result. And we have another one report of Hurdal.
Psych DSEC or DMEC for Fuchs endothelial dystrophy results from randomized study. This report is recorded and we are going to listen to it at the last international section. That is why, if you wish to have discussion, we could have it now about the first session. I would like to thank everyone who took part in listening and reporting, and this is not accidentally that the pathology of cornea has opened our congress, because as far as I am concerned, this pathology is more and more topical and it's becoming more and more severe. So that is why there were so many questions. Also, I would thank